Assalamu alaikum jami'an. Bismillahir Rahmanir Rahim. Today we are talking about the second part of the presentation regarding the general pharmacology. And as I mentioned in the first part, this topic is very important to understand all other sections related to the study of pharmacology, which is important basic sign for any physician and especially for anesthetists and those working in intensive care. In this part, there will be answering for the following several questions throughout this presentation, which are where is or are the sites of action of the drugs? Is it inside the cell or outside the cell or on the cell membrane? What's the difference between potency and efficacy of the drug? Which is the most potent muscle relaxant? Rocuronium, vicuronium, saxamethonium. Do the differences in potency of this muscle relaxant affecting our clinical use or not? How partial agonist drug produced antagonist effect? It is partial agonist, but can produce antagonist effect. What's the difference between synergistic or potentiated effects of a drug combination? Why stopping or changing beta blockers should be gradually stopping? What is the therapeutic window, LD50 over ED50, which is the safer drug, high or low therapeutic index? Other questions, what does ED50 mean in muscle relaxant? And what does it mean in other drugs? What's the difference between drug tolerance and drug intolerance? What is the tachyphylaxis? And what is the idiosyncrasy? The answers of all these questions will be explained throughout this presentation. And if any of these questions will not be answered, please allow me to answer it.
ها بس تعال انا
لا اليوم بس
ها
اليوم حيدر نور
نوري من الفراغ
لا مصري
من الصدر ها نوري نوري مساعد تحضير ايه بالعمليات بالعمليات نوري
شلون
تبقى بدار راح لا رحمة زين. يلا لا كل شيء لا انت تبديع وين الذكراوي مو على مود بس على مود العرف وين يوديهم يا عم. انا انسان مصلحتي. رحم الله عليك.
Okay, Shabab, we will continue.
تمام استاذ حاجة تسجيل.
Okay.
نعم استاذ استمر. هسه صوت كلش واضح.
In the first part, we talked in details about pharmacokinetics. And in this part, we will talk in details about the pharmacodynamics. And the pharmacodynamics is the study of what the drug does to the body, rather than the pharmacokinetic, which is the study of what the body does to the drug. And the pharmacodynamic is a quantitative study of the biological and therapeutic effects of the drugs. In the pharmacodynamics, there are several terms to be understood. From this term, the onset, which is the time it takes for the drug to elicit a therapeutic response. Peak, which is the time it takes for a drug to reach its maximum therapeutic response. Duration, the time a drug concentration is sufficient to elicit the therapeutic response. The mechanism of a drug action can be either by the acting on the cell membrane or acting on the metabolic processes within the cell. For example, enzyme inhibition, like cyclooxygenase, acetylcholine esterase. You know that aspirin acts on cyclooxygenase and the neostigmine acts on acetylcholine esterase. And the drug may act outside the cells. For example, osmotic diuretics like mannitol, antacids, and chelating agents. Regarding the action on cell membrane, the mechanism either by acting on the receptors, for example, acetylcholine receptors, or epinephrine adrenergic receptors. These drugs, atropine can act on muscarinic acetylcholine receptor, and propranolol can act on adrenergic beta receptors. And the action may be through the ion channels, like the voltage-gated sodium, potassium, or calcium. You know that lidocaine working on sodium, nitrogen, for example, working on calcium. And the mechanism may be through a carrier in the cell membrane, like sodium-potassium pump or proton pump. For example, you know, cardiac glycoside, you know that drug working to improve the cardiac function, digoxin, working on this pump. And there's physicochemical mechanism on cell membrane, which is general and local anesthetic, and alcohol appear to act on lipid, protein, and water constituent of nerve cell membrane. So by this mechanism can produce their specific effects. What is the receptor? Receptor is a macromolecular component of the organism that binds the drug and initiates its effect. Most receptors are proteins that have undergone various post-translational modifications such as covalent attachment of carbohydrate, lipid, and phosphate. So a receptor that is embedded in the cell membrane and functions to receive chemical information from the extracellular compartment and to transmit that information to the intracellular compartment. The binding of a drug to the receptor sometimes governed by several factors, like the affinity. Affinity means the inherent ability of the drug to bind with the receptor. Some drugs have higher affinity than others in regarding the ability to bind to certain receptors. And the efficacy means, which is the intrinsic activity, inherent ability of the drug to induce the desired therapeutic response. Means this drug able to produce the desired therapeutic response or not. It is inherent ability of the drug. And we have also the maximal efficacy, which is defined as the largest effect that a drug can produce. Now, what is the potency? Potency is how much a drug must be administered to elicit a desired response. Means to elicit the efficacy of the drug. If we look at this curve, here the potency and efficacy, if you look, the vertical axis for effect and the horizontal axis for potency. With increasing the dose here, the effect will be increased, right? While if we look on the right side here, for example, the drug C, whatever increasing the dose, regarding, I'm talking drug C, even if we reach here, increasing the dose, there will be no further increase in the efficacy. Why? Because this is a drug with low efficacy. If we're talking about drug A, the drug A need more dose than drug C to start the effect. But with increasing the dose, the efficacy of drug A increased.
شوي تشوف الكتابه او
هو عادي يعني يقول لك على حسب، بس هسه الدخول مالته هو ايش قد صار له يلا دخل.
احمد اي اتش 992. منو احمد اي اتش 900؟
نعم دكتور بلي.
احمد صار 3 مرات اسوي لك ميوت.
عم اسف لان ما جاي يدخل على الزوم، واحنا بمركز الامل يعني هسه رتبنا انه الوقت
عزيزي
انا والاستاذ مالتنا الاخصائي يسوي ندخل. بلي عمي اسف.
عزيزي انا صار 3 مرات اسوي لك ميوت، المحاضره مالتي مخربها، فسوي لنفسك ميوت وش تريد.
اسف عمي لين
تريد السولف سولف
عشان يطلع عمي من البرنامج من الزوم ترى.
ادري من يطلع. ليش تحكي يا اخي؟ محاضرتنا خربتها، صار 3 مرات اسوي لك ميوت انا. ارجع وانت سايلنت و100 اهلا وسهلا بيك.
اسف استاذ.
ترجع تصيح.
اسف استاذ اسف.
مالتنا خربت من وراك.
اسف استاذ الله يحفظك.
If we look at the curve on the right side, for example, if we compare a drug A with the drug D, for example, the drug A starting the action with lesser dose than that of drug D. So we can say that drug A is more potent than drug D. Why more potent? Because drug A can produce effect with lesser dose than that of drug D. While with increasing the dose, drug D can produce more efficacious effect than drug A. So the drug A more potent than the drug D, while the drug D more efficacious than the drug A. I wish from you to understand this very well, that the potency related to the dose and unrelated to the effect, while the efficacy related to the effect beyond the regard of the dose. So here is the efficacy and here is the potency. And some drugs cannot reaching the higher efficacy because this is inherent effect of the drug and cannot reach the higher efficacy whatever the dose increasing. While other drugs can increase the efficacy with the increasing the dose. Now, which is the most potent muscle relaxant? Rocuronium, vicuronium, dexamethasone. Which one is more potent? Arij Khalid.
نعم أستاذ.
Which is more potent, Arij?
المور بوتنت اللي هو يعني with less dose. يعني مثلا روكرينيوم احنا we can produce muscle relaxant with dose 0.3 milligram per kg.
What about vicuronium?
vicuronium يمكن vicuronium 0.06 or 0.07. So vicuronium is more potent. As I think
vicuronium
more potent. Yes.
more potent لأنه
more potent. This dose.
The normal dose of vicuronium is 0.1 milligram per kg. The normal dose of rocuronium 0.6 milligram per kg.
0.6.
The dexamethasone dose
1 or
1 milligram.
yeah. 1 milligram per kg.
So we said that
الفيكرين
vicuronium is more potent than
more potent than
rocuronium more potent than hexamethonium.
نعم أستاذ.
Then another student. حمزة مصطفى. حمزة مصطفى. حيدر حسين. حيدر حسين.
أستاذ
نعم.
يعني معناتها إنه يعتمد على الدوز على
نعم.
الإفكتيف يعني على يعني مو هذا الدوز ريسبونس البوتنسي مال يعني drug يعتمد على يعني as long as the effective drug
This dose needed to produce effect.
الإفكت.
حسين أي.
نعم أستاذ.
شنو اسمك يا حسين؟
حسين عبد القادر عفوا أستاذ.
زين ليش ما تكتب عبد القادر؟ اسم حلو.
والله صحيح كان مكتوب ما أعرف والله أستاذ ما انتبهت.
يلا أوكي يا حسين. أوكي.
أنا عارف أستاذ.
حسين.
نعم أستاذ.
احنا عرفنا أنه there are different potencies, for example, for the appear example rocuronium, vicuronium, hexamethonium, different potencies. Do the differences in potency affect the clinical use?
العفو أستاذ regarding this drug يعني نفس الرocuronium.
Any drugs, but we are talking now about these drugs.
Generally, نعم أستاذ. العفو أستاذ هي in general potency طبعا يأثر على clinical use يعني as example where we talking about ketamine there is anesthetic dose and there is analgesic dose.
Okay. حسين. Okay. شكرا. In fact, the potency, clinically speaking, does not affect our clinical daily practice. Why? Why? Because this is more related to the manufacturing of these drugs. If we are talking about vicuronium, the vicuronium is the potent, so we need lesser dose to produce its clinical effect, so that the one ampoule or vial of vicuronium contains just 10 milligram of vicuronium. While if we are talking about rocuronium, which is less potent than vicuronium and need higher doses, the manufacturer increased the dose in the ampoule or vial of rocuronium to 50 milligram of rocuronium because we need more drug to produce the same efficacy. And if we are talking about hexamethonium, the manufacturer considered that the hexamethonium is less potent than vicuronium and rocuronium and manufacture a vial or ampoule of hexamethonium with 100 milligram. So in all these cases, relatively speaking, the dose manufactured to be suitable for single person. So the potency does not affect our clinical daily practice, And nobody saying I will not use rocuronium, for example, because rocuronium is less potent than bicuronium. Nobody say that I will not use hexametonium because hexametonium is less potent than rocuronium, because we are using suitable doses for the desired efficacy of these drugs. If we take another example, if we are talking about the opioids, the dose of fentanyl is 1 microgram per kg. The dose of pethidine is 1 milligram per kg. The dose of morphine about 0.1 milligram per kg. Wide range of doses from 1 microgram per kg to 1 milligram per kg. Means there are 1,000-fold between 1 microgram per kg and 1 milligram per kg. While we are using all these opioids, and nobody say that the fentanyl is more potent than the pethidine, so we are not using the pethidine because it is less potent than fentanyl. And the manufacturer consider that by prepare an ampoule of pethidine of 100 milligram and an ampoule for fentanyl of 100 microgram and an ampoule of morphine ranging between 5, 10, or 15 actually milligram. So if we look at that, the manufacturer considering the differences in potency and to prepare suitable doses to get the desired effect for these drugs, although the differences in the potencies. Here, if we look at this graph, this is the hydromorphine, and this is the morphine, and this is the codeine, and this is the aspirin. Hamza Mustafa.
نعم دكتور.
Hamza. Which is the more potent drug here?
العفو الهيدرو مورفين.
Why?
لأن الدوز يكون أقل حتى إنه
dose of hydromorphine to produce the desired effect less than that of morphine. Okay, Hamza?
نعم.
Which is more efficacious, hydromorphine or morphine?
نفس الشيء ممكن.
نفس الشيء. Although the differences in the potencies of these drugs, while the effect is the same. If we look at codeine, codeine is the least potency because we need higher effect to produce such efficacy. And if we look at aspirin, aspirin is the less potent than even the codeine, and aspirin failed to reach the desired effect in relation to codeine, morphine, and hydromorphine. So that sometimes whatever the increasing in the dose of some drugs couldn't reaching the desired or higher effect. As we are talking about the efficacy related to the effect of the drugs, also the side effect has efficacy and in relation to the potency. So here, this is the percentage of response. Here, there is the 50% of response. And if we look at this drug, here, there is the ED 50, effective dose 50. While if we increase the dose after that, increase the dose, there will be a side effect of an anxiety. And if we increase the dose of this drug also, there will be a side effect of sedation. And this is in red color, a drug in red color. Also, this is the effective dose. By this dose, we can produce the desired effect. But if we increase more the dose, there will be a side effect of sedation. And sometimes the side effect is so hazardous like that with respiratory depression. If we look at this drug, this is the effective dose, while increasing the dose more will lead to respiratory depression. What the drug can do? It is either mimic the physiological activity of the body's own molecules. For example, the effect of adrenaline, the effect of vasopressor, the effects of beta agonist, mimic the physiological activity of the body's own molecules, or can block the physiological activity of body's own molecules, like, for example, the effect of atropine, the effect of beta blocker, block the physiological activity. In relation to the effect of a drug on the receptor, we have agonist effect, which means it activates the receptor to produce an effect similar to that of the physiological signal molecule. Antagonist effect, it prevents the action of an agonist on the receptor, but does not have any effect on its own. يعني الانtagonist has no effect, just to prevent the action of an agonist on a receptor. Partial agonist, it activates a receptor to produce sub-maximal effect. Not like that of agonist. Agonist produce similar to the physiological signal molecule. While here, partial agonist, it activates the receptor to produce sub-maximal effect. So we call it partial agonist. But at the same time, antagonizes the action of the full agonist. ليش؟ لأنه هو قاعد بالreceptor will prevent the full agonist from doing its work. For example, spindolol, sprinolol have a beta blocking and intrinsic sympathetic effect. So the sympathetic effect of these two drugs are sub-maximal to the original effect of adrenaline, noradrenaline, and at the same time, these drugs prevent the epinephrine and norepinephrine from producing their full effect on this receptor by blocking these receptors. So saying that spindolol and exprenolol belong to beta blocker groups, but at the same time, these have intrinsic sympathetic activity or effect. Now, a drug with the receptor producing maximal effect, we call it complete or full agonist, like adrenaline with the receptor. A drug like with the receptor producing less than maximal effect, we call it partial agonist. Drug with the receptor producing no effect, block the effect, we call it antagonist. According to these questions, if we talking about mathematics, this is right only, because this is wrong, and this is wrong. Only this equation is right, plus 1 plus 1 equal to 2, while if we are talking about the clinical effect of drugs, all these equations are right in certain conditions. How? This is the effect of combination of drugs. If we are talking about 1 plus 1 equal to 2, we call it the addition effect. Response elicited by combined drugs is equal to the combined response of the individual drugs. For example, if we inject lidocaine plus bupivacaine, both of them are local anesthetic drugs, will produce combined effect, additive effect. Just like we give more dose of lidocaine alone or more dose of bupivacaine alone. So we can regard these two drugs as a single drug. And with increasing the dose of each one, will increase the effect of each one. And if we talking about morphine plus fentanyl using in the same time for the same patient, these two drugs will produce additive effect. Additive effect. The increase of any of these drugs will increase the effect, just like we are using single drug in higher doses. We have another effect of combination, which is named as synergism, which is just like 1 plus 1 equal to 3 rather than 2. If we inject two drugs with the same effect, are giving together and produce a response greater than the sum of their individual response. Here, there is an increase in the response more than that if we use each drug in separate way. The examples of the synergistic effect, the using of thiobentone for patient already has drank alcohol or opioids, there will be synergistic effect, exaggerated effect of the thiobentone. Or with the use of opioid and non-steroidal anti-inflammatory drugs, there will be synergistic analgesic effect more than that if we are using higher doses of opioid alone or non-steroidal anti-inflammatory drugs alone. potentiation in the equation of 0 plus 1 equal to 2. A drug which has no effect enhances the effect of a second drug so that it produces more effect than if we use the second drug alone. Example, the use of benzarazide with levodopa will increase the effect of levodopa more than that if we use levodopa alone. And the fourth combination effect is the antagonism, and in this combination, the result of 1 plus 1 equal to 0. Drug inhibits the effect of another drug. Usually, the antagonist has no inherent effect, activity or effect, like the use of fentanyl plus naloxone or isoprenaline plus beta blocker. One will antagonize the effect of another. We have two antagonist effects. It is either non-competitive or competitive. In non-competitive, antagonists bind irreversibly to the receptor. This is non-competitive. After producing antagonist effect, whatever increasing the dose of the original agonist, there will be no competition on the receptor, so the effect will be for the antagonist because it is irreversible. The effect of irreversible binding is equivalent to reducing the total number of receptors available for activation by an agonist. يعني كأنما احنا قللنا عدد الريسبتورز الموجودة لأنه عطلناها by irreversible binding of the antagonist. Regarding the competitive antagonist, bind reversibly to the receptor. So it produces receptor blockade by competing with agonists for the receptor binding. So in this situation, if we increase the dose of agonist, can displace the antagonist from the receptor and bind it, because here there is no irreversible binding. Actually, in this case, it is reversible. Reversible means by the increasing the dose of agonist can displace the antagonist and producing the agonist effect. So if an agonist and a competitive antagonist have equal affinity, both of them have equal affinity towards the receptor, then the receptor will be occupied by whichever agent, agonist or antagonist, is present in the highest concentration. The drug with higher concentration will occupy the receptor and produce its effect. There is another term which is the regulation of receptor sensitivity. Receptors are dynamic component of the cell, not a static, dynamic component, متغيرة. In response to continuous activation or inhibition, the number of receptors on the cell surface can change. So their sensitivity to agonist molecules also change. After changing the number of receptors, certainly their sensitivity to agonist molecule also changed. So there will be either upregulation of the receptors, which is also known as sensitization, or down regulation of receptors, which is also known as desensitization. If we talk about upregulation, which can happen in two situations. First, when there is a prolonged continuous use of receptor blockers, for example, beta blockers. In this situation, there will be an increase in the number of the receptor. The receptor just struggling to get the original response of the agonist by increasing their number. And the second situation can produce upregulation by inhibition of synthesis or release of the hormones or neurotransmitters, which is the original agonist of the receptor. So the number or dose or concentration of this agonist will be less, and the receptor to get the same original effect trying to increase their number. And vice versa, if we are talking about desensitization or down-regulation, in this situation can happen when there is a prolonged or continuous use of agonist. The continuous use of agonist produce exaggerated effect, and the receptor trying to return back to normal effect by decreasing their number. And in another situation, when there is inhibition or degradation or uptake of agonist. So if you look at this phenomenon, it is just like a defense mechanism of the body to abnormal changes in the number or concentration of the agonist, or in cases of pathological conditions. In this case, if we have a hypertensive patient on atenolol, has developed newly asthma with mild bronchospasm. Hind Karim. Hind Karim. لينا نصير.
نعم أستاذ.
لينا هاي الكيس جات مريض hypertensive on atenolol and now in asthma, mild bronchospasm. What's your management regarding the atenolol?
ما أعرف.
Okay, Nina, thank you. Hanan.
نعم أستاذ.
Your management.
سؤال عن عاداتنا.
Okay, thank you, Hanan. منتظر مجيد.
نعم أستاذ.
Your management.
يعني changing to more cardio selective drug حتى ما يأثر على يعني.
Okay, thank you. Atenolol is beta blocker, and beta blocker produced physiologically. Beta blocker produce bronchoconstriction and the bronchoconstriction exacerbate the asthma. And this patient, newly developed asthma, means originally hypertensive on atenolol, and there was no problem previously regarding the atenolol, but after developing of asthma, there will be disaster effect of using atenolol for patients with asthma. This is number one. Number two, if we stop atenolol in abrupt way, there will be exaggerated hypertensive effect, exaggerated increase in the blood pressure. Why? Because of the phenomenon of upregulation. Patient on atenolol, chronically on atenolol, be an increase in the number of receptors. So after stopping of atenolol, the adrenaline, noradrenaline, producing exaggerated effect due to an increased number of receptors. So in this situation, there will be an increase in blood pressure, severe hypertension. So it is wrong to stop beta blocker in abrupt way, and should be changed gradually to other antihypertensive agent, gradually decreasing the atenolol and gradually prescribing another antihypertensive effect to avoid the phenomenon of upregulation. While if the hypertensive patient on atenolol and presented with severe asthmatic attack, severe, بعد من نحكي على severe asthmatic attack, no role of atenolol because it is severe asthmatic attack. We have to stop atenolol and expected severe hypertension, and this should be happen in the hospital, and treating of this shooting of blood pressure by using IV antihypertensive agent in the hospital and under continuous monitoring. So this is the second dose is emergency case, and the emergency case need aggressive management by stopping atenolol, expecting increase blood pressure, managing of this increase in blood pressure by monitoring and using of IV rapid onset antihypertensive drugs till the decreasing the effect of upregulation phenomenon. Now we are reaching the ED50. ED50 means the average effective dose, the dose that is required to produce a defined therapeutic response in 50% of population. The ED50 can be considered a standard dose, and it is the dose selected for initial treatment. And we have the LD50, which is the average lethal dose, is the dose that is lethal to 50% of animal treated. Why we say animal? Because there is no wise to experimental trials on a human, and we expect the lethal effect. And the TD50 average toxic dose is the dose that causes adverse effect at an incidence severity not compatible with the targeted indication in 50% of subjects treated. So here we have three terms: ED50, LD50, TD50. The therapeutic index has several names. We call it also the therapeutic window, the therapeutic ratio, the safety window. All means the same meaning, which is a comparison of the amount of therapeutic agent that causes the therapeutic effect to the amount that causes toxicity. So it is a measure of a drug safety. مقياس لسلامة الدواء. So it is the ratio of LD50 to its ED50 in animal. LD50 over the ED50. Or it is a ratio of TD50, toxic dose 50, to its ED50 in a human. TD50 over the ED50. Which is the safer drug? High or low therapeutic index means the number of which one, the number of this ratio. Which is better, to be high number or low number? Zina Khalid.
نعم أستاذ.
Which is better?
The high therapeutic index أستاذ.
Can you explain that?
دكتور هو حتى نوصل للتوكسيك دوز احنا نحتاج دوز عالي فتقلل النسبة يعني.
Good. تزداد النسبة قصدك.
أقصد تزداد عفوا.
A large or higher therapeutic index indicate that a drug is relatively safe. A patient, in this case, would have to take a much higher dose of such a drug to reach the toxic threshold than the dose taken to elicit the therapeutic effect. For example, furosemide, paracetamol, propofol, all these drugs can be used with very high doses without getting the side effect or the toxic effect of this drug. While in converse way, a small or low therapeutic index indicate that the drug is relatively unsafe, and examples of these drugs, phenytoin, digoxin, lidocaine, all these drugs, when we are using any of these, we are so concerned about the toxic effect and using these drugs with cautions, slowly, with monitoring to avoid the toxic effect. Why? Because these drugs with low therapeutic index. But sometimes the therapeutic index may produce some sort of confusion for you, as the TD50 over ED50 may produce that we want to decrease the TD50. Actually, here we want to increase it as the increase in the TD50 will produce more safe drugs and ratio rather than decreasing TD50. What does ED50 mean in muscle relaxant and other drugs? Reem Ahmed.
نعم أستاذ.
What does it mean?
العفو أستاذ ما فهمت السؤال يعني شلون؟
احنا حكينا على ED50 مو؟
نعم.
What does it mean in muscle relaxant and other drugs?
اسفه ما اعرف.
Okay, thank you. Sarah Mzahem.
نعم أستاذ.
What does it mean?
يعني in other drugs 50% of population يعني present the therapeutic effect.
Right.
بس بالمصل ريلاكسنت يكون يعني 50% من البوبوليشن يعني ريسكي دوز أقل يعني بالنسبة للدرج الأخرى.
Okay, thank you. The ED50 in other drugs we talk about means the drug can produce the desired effect in 50% of population, and in this case, it is logically to start with ED50 dose. And if the patient does not get a response, we can increase the dose. While the ED50 in muscle relaxant drugs means another meaning, has another meaning. According to Miller, and you know Miller is a textbook of anesthesia, the potency of non-depolarizing muscle blockade is the potency of these drugs, neuromuscular blockade drugs, is described as the effective dose in muscle relaxant. The dose of a neuromuscular blocking drug required to produce an effect. This effect may be 50%, 90%, 95% depression of twitch height, commonly expressed as ED50, ED90, and ED95 respectively. So ED50 and muscle relaxant means there is 50% depression of twitch height. What does it mean, twitch height? Twitch height. We have a device, if you know it or not, monitor of neuromuscular activity, نسميه nerve stimulator بالعامي. Actually, it is good monitor for neuromuscular activity. But after giving a stimulus, there will be a twitch for the normal muscle. After giving muscle relaxant, this twitch expected to be decreased. And the decrease in the twitch by 50%, we call it what? We call it AD50. Means there's 50% depression of twitch height. And the decrease in the twitch by 90%, we call it 90% depression, means ED90. And the decrease in the twitch by 95%, we call it the ED95. Thus, the ED95 is the amount of neuromuscular blocking drugs, يعني muscle relaxant, required to reduce the twitch height by 95%. By 95%. Here, the ED95%, 95, for commonly used non-depolarizing muscle relaxant. The ED95, sorry, not 50, the ED95 for rocuronium is 3.31, and that for bicuronium 0.04, for panicuronium 0.07, for cisatracurium 0.04. So we know from this number 0.31 that by this dose 0.31 of rocuronium, the height of the twitch decreased by 95%. By 95%. And accordingly, we can use the induction dose. The induction dose, for example, of rocuronium rocuronium, is 1.9 to 3.2 that of ED95. نحولها إلى الدوز المليغرام راح تطلع 0.6 to 1 milligram per kg. And in the same manner, we can calculate the effect of other muscle relaxant on the height of twitch, and from this effect, we can use the desired dose for induction, which is also called the intubating dose. That is different from the maintenance muscle relaxant dose. Now we are reaching the adverse drug reaction, which means there are either life-threatening response to drug, or allergy, or harmful, noxious, unintended, undesirable response to drug, or an unpredictable response to drug. All these regarded as adverse reaction to a drug. And this can be range from side effects, toxicity by overdose, allergic reaction, physical dependence, and carcinogenic effect. The side effect means unavoidable, unintended pharmacodynamic effects that occur at a therapeutic dose. For example, if we give an atropine, one of the side effects, dryness of mouth. And this side effect in the same range of therapeutic effect. So this is unavoidable. Whenever we use atropine, there will be dryness of mouth. But why we are using atropine? Because the advantage of using atropine for certain clinical conditions more than that the disadvantage of using atropine, which is the producing of dryness of mouth and other side effects. Toxic effect results of the excessive pharmacological action of the drug due to overdosage or prolonged use. For example, hepatic necrosis from paracetamol overdose. So in normal condition, there is no hepatic necrosis, but by increasing the dose of paracetamol widely, there will be toxic dose of paracetamol. Drug intolerance, when the side effects of a drug in an individual at the therapeutic doses. For example, vomiting with a single dose of salicylate. This vomiting sometimes reaching the level that the drug intolerant for the patient. So for a silly side effect, the patient can get rid from this drug due to the intolerance. And we have drug tolerance, which is another definition unrelated to drug intolerance, which means the decreased response to the same amount of a drug after repeated administration. Tolerance, we have several types of tolerance, and patients who are tolerant to a drug require higher doses to produce effect equivalent to those that could be achieved with lower doses. Three categories of tolerance. First one, pharmacodynamic tolerance, metabolic tolerance, and tachyphylaxis. The pharmacodynamic tolerance refers to the familiar type of tolerance associated with long-term administration of a drug, for example, morphine and heroin. It is thought to result from adaptive processes that occur in response to chronic receptor occupation. Metabolic tolerance is defined as a tolerance resulting from accelerated drug metabolism caused by the ability of certain drugs to induce synthesis of hepatic drug metabolizing enzymes. If you remember, we explained that in details in the first part of general pharmacology presentation last week, and we said there are several drugs regarded as enzyme inducer and other drugs regarded as enzyme inhibitors. And here, some drugs regarded as enzyme inducer with the time will enhance the metabolism of the drugs and lead to need for increasing the dose to get the same desired original effect. Tachyphylaxis is a form of tolerance in which a reduced drug responsiveness caused by repeated dosing over short time. And this is the difference from the tolerance in general. It is a matter of repeated dosing over short time, rapidly occurring tolerance to certain drugs. And this is unlike pharmacodynamic and metabolic tolerances, which take days to develop. For example, this can happen in the use of transdermal nitroglycerin. Cross tolerance. Tolerance for a drug that develops after administration of a different drug. For example, if we use morphine and morphine produce a tolerance and we need higher doses of morphine to get the same original effect of morphine, and we give this patient pethidine in replace to morphine, there will be also tolerance to pethidine originally. Why? Because the patient was on morphine and now we are giving the pethidine, which is the same group and effect. So the tolerance will involve the pethidine also, not only the morphine. Cumulative effect, increased effectiveness when a drug is given in several doses. And this is opposite to tolerance. When increasing the dose, the effectiveness will be increased. And this can happen with the use of thiopentone. Drug dependence, the patient becomes accustomed to the drug's presence in his body. And if we not give the patient the drug, there will be severe withdrawal symptoms. Idiosyncrasy, an abnormal physical reaction by an individual to a food or a drug. Drug effect unique to certain individual than others. يعني نفس الدواء تطيد كل العالم ما يصير فيهم شيء، تطيد شخص معين ممكن يصير عنده toxic reaction, allergic reaction, a reaction peculiar to the patient, like, for example, an anaphylactic reaction. Drug allergy, immunologically mediated reaction, symptoms unrelated to pharmacodynamic profile of the drug, independent of the dose. And sometimes this can happen after very low dose, few drops of any drugs, and the famous example is the allergy to penicillin. A drug withdrawal symptoms after stopping, for example, of beta blockers. We talk about that. Photosensitivity, cutaneous reaction resulting from drug induced sensitization of the skin to ultraviolet radiation, for example, quinolones. Teratogenicity induced birth defect, capacity of certain drugs to cause fetal abnormalities, and the famous example is thalidomide. أحد سامع بالثاليدومايد؟ Nobody? Thalidomide has been
العفو دكتور، الثاليدومايد مو كانوا ينطوه انتي ايميتيك بالبريجنسي، بس كانوا يسوي فد congenital anomaly لللمس مال بيبي.
Very good.
يطلع
يعني
بدون لمس.
هذا هو سوى فد ديزاستر بالخمسينات تقريبا من القرن السابع، سوى loss of some limbs of the body، يعني يعتبر teratogenic، فيعتبروه famous example of the teratogenesis. And sometimes the drug produced mutagenic effect, and the mutagenesis involves alteration of the genotype by modification of the DNA. The mutation is carried to the next generations also. Now, we have several mechanisms of drug interactions. Some of these mechanisms in relation to pharmacokinetic interactions, either via absorption, distribution, biotransformation means metabolism, and excretions. So in all phases of pharmacokinetic, there may be interactions between drugs. And also we have a pharmacodynamic interactions in relation to receptor interactions, receptor sensitivity, neurotransmitter release, drug transportation, electrolyte balance. And we have also interactions due to physiological functions and pharmaceutical interactions. And we have direct chemical or physical interactions. In relation to pharmacokinetic interactions, drug interactions can affect all four basic pharmacokinetic processes. When two drugs are taken together, one may alter the absorption, distribution, metabolism, or excretion of other drugs. For distribution, there are two principal mechanisms by which one drug can alter the distribution of another: by competition for the protein binding, as if you remember the example we talked about the warfarin and aspirin in the previous last presentation, or by alteration of extracellular pH. When two drugs bind to the same site on the plasma albumin, co-administration of those drugs produces competition for the binding. As a result, binding of one or both agents is reduced, causing plasma level of free drug to rise. In theory, the increase in the free drug can intensify effect, means there is exaggerated effect of the displaced more free drugs than the original drug when this drug used alone. Altered metabolism is one of the most important and most complex mechanisms by which drugs interact. Some drugs increase the metabolism of others, and some drugs decrease the metabolism of other drugs. So we talk about that enzyme inducers, which enhance the effect of enzymes, lead to enhance the metabolism of other drugs, and the example of enzyme inducers are barbiturate, rifampicin, phenytoin. And we have enzyme inhibitors decreases the metabolism and prolong the effect of other drugs. So we have to be so precautions about the use of these drugs because there will be exaggerated, prolonged effect of these drugs. The enzyme inhibitors example, cimetidine, ketoconazole, erythromycin, and others. In pharmacodynamic interactions, there are of two basic types. Interactions in which the interacting drug act at the same site, or interactions in which the interacting drugs act at separate sites. They may be potentiative or inhibitory and are of great clinical significance. Interactions at the same receptor almost always inhibitory, like the use of beta blocker, which compete the noradrenaline. Interactions resulting from actions at the separate site may be potentiated or inhibitory. Receptor interactions, either competitive or non-competitive, sensitivity of the receptor depend on the number of receptors and affinity of the receptors. Alter neurotransmitter release or drug transportation. Alter water or electrolyte balance. Now the interactions resulting from actions at separate sites. Separate sites, not on the same receptor. The interaction between two diuretics, for example, hydrochlorothiazide and spironolactone. These are different two diuretics. The hydrochlorothiazide act on the distal convoluted tubule of the nephron to increase the excretion of potassium, while the spironolactone, regarding a potassium-sparing agent, work to decrease renal excretion of potassium at a different site in the kidney. Consequently, when these two drugs are administered together, the potassium-sparing effect of the spironolactone tend to balance the potassium-wasting effect of hydrochlorothiazide, leaving the renal excretion of potassium at about same level it would have been had no drugs have been given at all. يعني كأنما ما نعطي ولا دواء in regard of the potassium concentration and level. So if we are aware about all the interactions effect of all drugs, we can choose the suitable drugs to decrease the side effect. Can you imagine if we use two drugs, both of them decrease the potassium level, there will be exaggerated decrease in the potassium leading to severe hypokalemia. But here the wise use of an opposing effect of on potassium of two different drugs just lead to keeping the potassium just like normal. In physiological interactions, drug A and drug B bind to different receptors on the same tissue but give opposite or similar effects. For example, the use of aspirin lead to antiplatelet effect. The use of warfarin lead to anticoagulant effect. Both of these effects increase the bleeding. So this is a type of physiological interactions. Two drugs lead to increase the bleeding by two different separate two sides mechanisms. Chemical or physical interactions. Some drugs, because of their physical or chemical properties, can undergo direct interaction with other drugs, usually render both drugs inactive. Never combine two or more drugs in the same container unless it has been established that a direct interaction will not occur. Why? Because this combination renders both drugs inactive. So we will lose the effect of these two drugs and sometimes lead to morbidity of the patient by preventing the stopping of pathological conditions. The famous example is thiopentone. Always those who are using the thiopentone do not mix the thiopentone by any another or other drugs, because this leads to physical and chemical interaction and precipitation of the thiopentone combined with that drug. Regarding the pharmaceutical interactions, the chemical or physical interactions, for example, use of vitamin C with amphotericin B or vitamin C with penicillin. Minimizing adverse drug-drug interactions. How? By the most obvious is to minimize the number of drugs given to the patients. Second, and equally important way to avoid detrimental interactions is to take a thorough drug history. How? For example, patient with hypertensive, heart failure. We have to know the drug history, patient on glycerol trinitrate, on, for example, angiotensin converting enzyme inhibitors, on beta blocker, on diuretic, and we want to prescribe another drug. We have to know the history of a drug and to consider the possible expected interactions of these drugs with the new planning prescribing of a drug. And there is also drug-food interactions, which is also important and poorly understood because research has been sorely lacking. Aku defect in these researches for the food-drug interactions, but it is still important and to be considered. They are important because they can result in toxicity or therapeutic failure. Reducing the rate of absorption merely delays the onset of effect, while the peak effects are not lowered. In contrast, يعني اعتبر هاي بسيطة مال reducing the rate of absorption. مجرد يأخر the onset of effect. In contrast, reducing the extent of absorption, reducing the intensity of peak response, لأنه أصلاً ما صار absorption. The effect will be lost or decreased. The interaction between, for example, calcium-containing foods and tetracycline antibiotics is perhaps the classic example of food reducing drug absorption. لذلك whenever we prescribe tetracycline, give an instruction to the patient to avoid taking tetracycline with the calcium containing foods like the dairy products. Tetracyclines bind with calcium to form an insoluble and non-absorbable complex. So if tetracycline are administered with milk products or calcium supplements, absorption is reduced and antibacterial effect may be lost, so the growth of bacteria will be exaggerated. High fiber foods can reduce the absorption of some drugs. For example, absorption of digoxin is reduced significantly by wheat bran, rolled oats, and sunflower seeds. Since digoxin has a low therapeutic index, reduced absorption can result in therapeutic failure. And therapeutic failure of digoxin, not like the therapeutic failure of paracetamol, because it is so important vital medications used when there is indication for a patient with heart failure. And this may lead to heart failure and the symptom and signs of pump failure. The grapefruit, I don't know why, is a major food that lead to several interactions and so dangerous interactions with many drugs. And it is the most dangerous food can produce interaction with several drugs. For example, the grapefruit juice can inhibit the metabolism of certain drugs, lead to increase the blood levels of these drugs. In one study, co-administration of grapefruit juice produced a 406% increase in the blood level of philodipine. Can you imagine? 40% increase of philodipine, and the philodipine is antihypertensive, and this lead to severe dropping in the blood pressure and lead to severe disaster complication. The same, the combination of grapefruit with terfenadine, cyclosporine, philodipine, other medications, producing such increase in the levels and exaggerated the effect of these drugs. Another important effect of food drug toxicity, the most dramatic example is the interaction between monoamino oxidase inhibitors, which is a family of antidepressant drugs, and food rich in tyramine. Tyramine is amino acid and rich in certain foods like aged cheese or yeast extracts, and the interaction between these foods that are rich in tyramine with monoamino oxidase inhibitors lead to increased blood pressure to a life-threatening level. Yani an increase in the blood pressure may lead to CBA, may lead to MI, and you know CBA, MI, not a silly pathological conditions, and may lead to an increase in the morbidity or causing the mortality of this patient. So we have to be aware about important famous drug-food interactions to give a precautions to the patient for them these drugs prescribed to avoid such hazardous complications. Food may also rarely have a direct impact on drug action. For example, foods rich in vitamin K, like broccoli, Brussels sprout, cabbage, can reduce the effects of warfarin, which is an anticoagulant. And the producing effect of warfarin lead to more thrombosis, more incidence of embolism. Drug features associated with potential interactions. Drug with narrow therapeutic index. We talked about therapeutic index. These drugs with narrow therapeutic index very easy develop the therapeutic signs and symptoms, therapeutic toxicity with small increasing in the doses beyond the effective doses, like the phenytoin, cyclosporine, and theophylline. And the drugs with sharp response curve, like phenytoin, aminoglycoside, and vancomycin, and dose-dependent سموها Michel's Mantin kinetic, like the phenytoin. So if you look about all the three mechanisms, in all of them, phenytoin is included. So it is very risky drug, and when we prescribe it, we have to give severe precautions. List of drugs that most common interacting drug: antacid, cimetidine, digoxin, warfarin, theophylline, ketoconazole. Pregnancy considerations for drugs. In pregnancy, there is an increased maternal heart rate, cardiac output, and blood volume. This is physiological increase, as what are produced to you during the physiological changes in pregnancy lecture may affect absorption, distribution, and effectiveness of the drugs. Number one. Number two, drugs may cross placenta, like what we talked in the last presentation, and the drug may be teratogenic. Drug may cross into breast milk. So these to be issues to be considered when we prescribe a drug for the pregnant woman. And accordingly, the drugs categorize into groups from 5 groups, A, B, C, D, X. And in these groups, if we regarded the drug as group A, means there is a controlled studies in pregnancy, and the risk is less than 1%, so relatively regarded as a safe drug. And in B group, there are animal studies show no risk, inadequate human data, but there are no studies regard on human. And in group C, animal studies show risk, inadequate human data also. In group D, there is a human data that show risk, so benefit may outweigh the risk. In group X, animal or human data positive for risk, use unwarranted. Here, regarding there are several differences when we deal with the neonatal pediatric age group in relation to pharmacokinetic. There are factors produced to decrease the absorption in pediatric age group. For example, the gastric pH, less acidic pH, gastric emptying is slow, decreased oral absorption, the skin is thinner, so expected increased topical absorption, the intramuscular absorption faster and irregular. The younger the person, the greater the percent of total body water. Greater total body water means fat content is lower, decreased level of protein binding, immature blood-brain barrier, so more drug enter the brain, body surface area, weight-based dosing important, better than per kilogram. The use of drugs depend on body surface area in pediatric age group, better than that depending on or based on weight. In metabolism, there is still the liver immature, does not produce enough microsomal enzymes, but for older children may have increased metabolism requiring higher doses than infant. And for excretion, kidney immaturity affect glomerular filtration rate and tubular secretion. Decrease also perfusion rate of the kidney may reduce excretion of the drugs. If we deal with elderly group age, which regarded as persons over 65, we will face an increased incidence of chronic illnesses. So those patients mostly on other use of drugs to manage the chronic illnesses. So better to consider the new prescribing drugs to avoid the side effect and avoid the interactions. And for them, elderly age group, the absorption also affected by gastric pH less acidic, slowed gastric emptying, movement through GIT tract slower, decreased blood flow to the GIT tract, decreased absorptive surface area due to flattened intestinal villi. And regarding the distribution, total body water percentage lower, decreased fat content and decreased muscle mass, decreased production of protein by the liver lead to increased protein binding of drugs and increase the circulating of free drugs. So increase the effect of these drugs. And regarding the metabolism, the aging liver produces fewer microsomal enzymes affecting drug metabolism and reduced blood flow to the liver. And the changes regarding the excretion, decreased glomerular filtration rate, decreased number of intact nephrons. Also, another condition which is important to be considered when prescribing drugs, we mentioned the pediatric age group, we mentioned elderly age group, we mentioned the pregnancy, and now another important condition is the obesity. In the obesity, we depend on body mass index, which is equal to body weight in kilogram over the height square in meter. And accordingly, we categorize the weight into underweight, normal, overweight, obese 1, obese 2, morbidly obese, and super morbidly obese. And you can find different categorization, different classification, and it does not matter, but I put that because it is so an inclusion of all the types of obesity and the underweight. Total body weight is the exact weight, while the ideal body weight, according to phenomenon regarded as a in male height minus 100 in female height minus 105. So we can, according to from these two ways, we can conclude the lean body weight, which is according to Cunningham phenomenon equation, equal to ideal body weight plus. This is the ideal body weight, the same ideal body weight plus the result of total body weight minus ideal body weight. For example, إذا واحد ideal body weight هو 100 والtotal body weight قسناه طلع 160. فهنا اللين body weight راح يبقى هذا ال 100. شو نضيف له؟ نضيف له 160 ناقص 100 60. هاي ال 60 نضربها في 0.25 يعني راح شو يبقى من ال 60 راح يبقى 15 فراح نقول اللين بادي ويت هو 115 and it is better to deal with the body according to lean body weight rather than the ideal body weight. And in certain medications, we have to deal with the body according to total body weight. In obesity, there is a change in the volume of distribution affect the bolus dose. How? Highly lipophilic drugs, for example, fentanyl, propofol, diazepam, we have to increase it. Why? Because there is volume of distribution increase, and this volume of distribution increase due to fat rather than water. So the injection of highly lipophilic drug will decrease the concentration of these drugs due to an increase in the volume of distribution. And according to the equation have been studied in the last presentation, we have to increase the dose of lipophilic drugs. And for another group of drugs, which is less or no lipophilic drug like muscle relaxant and pneumostigmine, no need to increase the dose because for these drugs there will be no increase in the volume of distribution and no decrease in the concentration. And in the obesity, there's a change in the clearance. And if you remember in last presentation, the clearance affect the maintenance dose. So it may be due to this changes in the clearance, may be due to changes in the metabolism by drug, lead to an increased metabolism, for example, of halothane, enflurane, benzodiazepine, or decreased metabolism, for example, in propranolol, or there is an increase in the excretion by kidney due to an increase in the GFR, like that with cimetidine. Or there are other causes like an increase in pseudocholinesterase that lead to giving hexamethonium according to total body weight rather than the lean body weight due to an increase in the level of pseudocholinesterase in the obese patients. Thank you very much. If you have any question or comment, I'm happy to hear from your side.
استاذ بس بدون زحمه الايديال بادي ويت يعني هاي ال 100 وال 105 كونستانت يعني ثابتات.
هاي طبعا اذا تاخذين الايديال بادي ويت اكو multiple phenomena, multiple equations to take the ideal body weight. هاي وحده من عندهن اللي انا ذكرتها اللي هي famous one ونقدر نستفيد من عندها. بس تقولي لي هي هاي الوحيده، اقول لك لا، اكو other equations.
دكتور يعني احنا ننقص الهايت من 100 لو بس ناخذ 100؟
شلون؟
يعني ننقص بالميال، ننقص الهايت من 100 بالايكويشن هذا؟
نعم. يعني واحد وزنه طوله 170، طوله 170 ناقص 100 الايديال بادي ويت مالته 70.
اوكي دكتور، شكرا جزيلا.
Any other questions or comments?
العفو أستاذ، بس سؤال على مود السؤالين اللي فاتت مال البيشنت اللي severe asthmatic and hypertensive والبيشنت اللي hypertensive and bronchospasm. بس العفو أستاذ، يعني اثنيناتهم direct discontinuation of drug and change with other drug لو يعني
أول حالة gradual decreasing in the dose of atenolol, and to avoid an increase in blood pressure, this has to be associated with giving another antihypertensive drug with small doses and gradually increase. So gradually decreasing the atenolol, gradually increasing the new antihypertensive drug to avoid the withdrawal symptom. بالحالة الثانية المريض جاينا دا يموت severe status asthmaticus، فما معقولة هذا نبقيه على الاتينولول، وإنما نوقفه. إذا نوقفه راح يزداد الضغط، إذا ازداد الضغط وهو يمنا بالمستشفى عندنا multiple hypotensive agents ممكن نستخدمها حتى باي اي في يوز، مثل الجليسرايد راينايتريت، صوديوم نيتروبروسايد، لابيتالول، هواية عندنا أدوية. هاي الأدوية ممكن نستخدمها with continuous monitoring till the disappearance of the withdrawal symptom due to upregulation of the receptor.
أوكي أستاذ، شكرا جزيلا.
Any other questions or comments?
أستاذ بلا زحمة effective dose 95 of muscle relaxant، بس إذا ما بيها زحمة توضحها لأن اتصل النت.
اللي سألتي السؤال سامعة بجهاز اسمه نيورو ماسكولار مونيتورينج أو نيرف ستيميليتر بالعامية يسموه، سامعة بي؟
ما أتذكره صراحة.
اكو جهاز زين اسمها نيرف ستيميليتر بالخطأ، يعني واحد نستخدمه بالريجنال انستيزيا، وبتر انه نسميه نيرف لوكيتر مو نيرف ستيميليتر. واكو جهاز اسمه نيرف ستيميليتر المقصود به نيورو ماسكولار جانكشن مونيتورينج. فهذا الجهاز في اكثر من مود، واحده من المودات من نعطي ستيمولاس راح يعطينا twitch height according to the contraction of the muscle. فاني هسه ما بي شيء، ما ماخذ muscle relaxant، اذا يسووا لي stimulation لمصل معينه التويتش هايت راح يطلع كامل، بهذا الجهاز. زين، اذا انطينا muscle relaxant وسووا لي stimulation التويتش هايت راح يقل. فالإفكتيف دوز اللي تقلل التويتش هايت تو ذا هالف، يعني يطلع الهايت اوف ذا تويتش نصه، هاي شو يسموها؟ يسموها ED 50. الدوز
اوكي
اللي تطلع لي التويتش هايت بس 10%، يعني 90% ما موجود، يسموها ED90. الدوز اللي تبقي لي من التويتش هايت only 5%، يعني 95% تروح تختفي، شو يسموها؟ يسموها ED95. فمن هاي احنا نعرف يا دوز من الروكيورونيوم، يا دوز من الروكيورونيوم تروح لي 95% of the twitch. هاي الدوز هي 0.31. هاي ال 0.31 قد تفيدنا بالمانتننس دوز، بس ما تفيدنا بالانتوبيشن دوز لان نحتاج اكثر. فشو نسوي؟ ناخذ about 2 ED95 دوز، يعني 2 دبل. فايش تطلع عندنا؟ تطلع عندنا 0.6 ملي جرام بير كي جي ممكن نستخدمها فور انتوبيشن. واضح؟
اوكي دكتور، عشت ايدك.
وبعد سؤال او كومنت؟
العفو استاذ، بس سؤال اذا ممكن. العفو استاذ، بس سؤال اذا ممكن.
تفضلي.
بين التوليرانس والديبندنسي، احنا قلنا التوليرانس هي decrease بالريسبونس بس السيم اماونت مع الدراجز، بس مجرد راح يقل الريسبونس بعد repeated administration. زين الديبندنسي هم راح يقل الريسبونس لو راح يعني يريد يزيد الدوز مع الدراج.
الديبندنس غير موضوع، غير موضوع. ممكن التوليرانس والديبندنس both of them ممكن تعتبر both of them occur in the same patient for the same drug. ممكن، بس إنه two different issues. التوليرانس يقل الإفكت unless we increasing the dose. الديبندنسي معناها إذا الدواء خلص، يعني البيشنت راح يعني يحتاج هذا الدراج لانه راح تطلع عنده يسموها withdrawal sign and symptom، لانه البادي مالته accustomed for this drug and without this drug راح تطلع عنده sign and symptom. مثلا for example السموكينج بنيكوتين والجسم يتعود على النيكوتين، فهنا لما نوقف السموكينج ايش راح يصير؟ راح تطلع عندنا withdrawal sign and symptom due to dependence. بس احنا هنا ما عندنا tolerance. اذا ناخذ مثال ثاني، المورفين، واحد يتعود جسمه على المورفين، فاذا خلص المورفين من جسمه راح تطلع عنده withdrawal sign and symptom. ليش؟ لانه اكو dependence on morphine. and at the same time by different mechanism هذا المريض عنده tolerance ايضا. tolerance يعني معناها احنا مو بس نحتاج المورفين وانما نحتاج increasing the dose of morphine.
شكرا.
اكو بعد سؤال او كومنت؟
العفو بس استاذ، بالنسبه للاديتيف افكت والساينرجستيك افكت، الاديتيف افكت هن دراجز من نفس الفاميلي، لان الامثله المذكوره كانت مثلا المورفين والفنتانيل اثنيناتهم مثل الاوبيويد. ساينرجستيك افكت كان بنزودازيبين واوبيويد.
نعم.
يعني هذه فد قاعده انه هيك شيء يكون من نفس الفاميلي الدراج هو الاديتيف افكت والساينرجستيك افكت؟
لا مو قاعده. او المثال الثاني شنو ذكرتي هسه؟
انه الساينرجستيك افكت كان بين البنزودازيبين والاوبيويد.
اي نعم، بس ممكن اكو تو analgesic effect belong to two groups but these two drugs have no synergistic effect, additive effect. ممكن يكون synergistic effect.
اوكي شكرا جزيلا استاذ.
اكو بعد سؤال؟ comment. Okay, thank you very much and goodbye.
ثانك يو دكتور.
شكرا أستاذ.
شكرا جزيلا لوقتك دكتور.
شكرا جزيلا دكتور.
شكرا دكتور.
شكرا أستاذ.